Yes, sir, we can start with the
Yeah.
session.
So today's topic is obstetric critical care. In the obstetric critical care, there are few area which is very important. One is your obviously preeclampsia, eclampsia, amniotic fluid embolism, postpartum hemorrhage, and the HELP syndrome. HELP syndrome you will get in the lab, in the CVS, or preeclampsia you can get in the CBS also, or you will get as a short case, either preeclampsia or postpartum hemorrhage. The obstetric critical care, one of the hot topic for EDIC exam. So every alternate year, they either give the case or they give in the lab value. So you have to know all about the HELP syndrome and preeclampsia. This two is the most common topic, and sometimes they can give of amniotic fluid embolism. So this is the case. This is about your 28-year-old primary gravida, 34-week gestation, present in ICU with headache, blurred vision, breathlessness for 6 hours, 190 by 115 mmHg is the blood pressure, heart rate is tachycardic, hypoxic, tachypneic, proteinuria present, bilateral infiltration, and lab value showing the low platelet, AKI creatinine is 1.9, AST, ALT, and LDH is higher, reflex is breaks, and urine output is low. So then the question was, what is your diagnosis and initial priority of management, and then the management of hypertension. The model answer saying that your diagnosis would be severe preeclampsia with pulmonary edema and multi-organ involvement. So if you give this answer, you will get full marks. Then obviously you have to give the differential diagnosis. But unless you complete severe preeclampsia, pulmonary edema, multi-organ involvement, renal, hepatic, and hematologic, they will not give you the full mark. So differential, peripartum cardiomyopathy, ARDS, pneumonia, that. So when we are talking about immediate priority, again, you have to approach airway breathing circulation. So airway breathing here, you have to tell about you will take care of the airway, you assess the airway. If the GCS is low, you will give airway protection, you will facilitate the maintenance of the oxygenation, because here the oxygen saturation is 86% on the air. So you have to take care of the oxygenation. Then your priority is the circulation. C is the control blood pressure reduction. And because it is a preeclampsia, so high chance of seizure, so seizure prophylaxis. And there is already there is a bilateral your chest X-ray showing bilateral alveolar infiltrate. So there is a pulmonary edema. So you have to talk about the fluid restriction and diuresis. And also because it's an obstetric case, so you have to utter the fetal assessment. These are your keyword. So you have to cover all these things. Then you can tell anything about your other management. Okay. Now, hypertensive emergency in pregnancy and in-organ dysfunction is the priority of management over here. Coming to your next, management of hypertension. So management of hypertension, when you will utter, don't jump on the drugs. So first, your target, gradual reduction. of the blood pressure. Targeted blood pressure will be systolic 140 to 150 and diastolic 90 or less. So avoid reduction more than 25% in the first hour. And first line of management, I will use the levotalol. If levotalol is not work, then we can add hydralazine or nicardipine. Avoid nitroprusside here. Just 1 minute. Hello. Sorry. So next is your seizure prophylaxis and control, fluid management, obstetric consideration, monitoring, supportive care, and complication. So seizure prophylaxis, yes, everybody after the magnesium sulfate, you have to tell the doses regimen also. So pictured per regimen, 4 milligram, uh, 4 gram IV over 5 minutes, then 10 gram IM, 5 gram each buttock. Then that is then 5 gram IM 6 hourly for 24-hour post delivery, and monitor your deep tendon reflex, respiratory rate, and the urine output. Treat toxicity 10 ml 10% calcium gluconate. If there is a magnesium sulfate toxicity, that time the examiner might ask, how will you understand that toxicity is happening? So features is it reduces the deep tendon reflex, the respiratory rate will be higher, and the urine output will be low, and patient may be agitated or drowsy. So fluid management of this patient, because there is a bilateral infiltration, strict fluid restricted, less than 80 ml, including the drug, input output chart, avoid fluid bolus here. Instead, fluid bolus, use furosemide because pulmonary edema is there, and consider non-invasive ventilation or intubation if refractory hypoxia, central venous pressure not routinely useful. You can do the echocardiography to evaluate the further fluid status in the lungs, B-line, IVC, whether collapsing is IVC collapsing or not, and the VTI is the more useful. Then you have to monitor supportive care, continuous ECG, invasive blood pressure, SpO2, urine output, serial labs, already you have mentioned, and fetal heart monitoring is very important. Avoid nephrotoxic drugs because already there is a creatinine high. Thromboprophylaxis once platelet more than lakh or bleeding risk minimal. Otherwise, thromboprophylaxis not